this guy.
Good morning. We'll go ahead and get started. Maybe we'll just do quick introductions of our panel, and we'll just go across the board, and then we'll get started. I know at 6:30 this is like a surgical meeting. I thought you guys got up later than we did, but we'll go ahead and get started. I'm Vinod Thorani, cardiac surgeon at Piedmont Heart Institute.
Hi, good morning, everyone. I'm Pradeep Yadav. I'm an interventional cardiologist, partner of Dr. Thorani at Piedmont Heart Institute.
I'm Matt Summers. I'm an interventional cardiologist, structural heart at Centera Heart Hospital, Norfolk, Virginia.
I'm Git Zani, interventional cardiologist from University Hospitals of Cleveland.
I'm Hassan Jalawi. I'm an interventional cardiologist at Cedars-Sinai in Los Angeles.
And good morning. I'm Prasad Dasi. I'm a professor at Georgia Tech and Emory, as well as the co-founder and chief technology officer of Dasi Simulations. Good morning.
Great. I know that Marty was unable to join us today, so Pradeep and I are going to moderate this session. And just to also, since I'm not going to have any slides up, I do have a conflict, and that's I'm the head of the advisory board for Dasi Simulation. So first, this is, to me, we think of TAVR now, over 1 million patients done. What is exciting about TAVR? And what's exciting about the technology going forward into mitral and tricuspid? And for me, there are a couple of things that stand out, and I'm actually not biased over this. This is one of the most exciting things that comes across for me. And in fact, we've been able to increase our volume to the type of patients we can do by probably 20%, including bicuspids and lifetime planning. And the reason we've been able to do that at the Heart Institute is because of using Dasi simulation so integrally into our components. So we're hoping that we can kind of spread some of what we've been doing in the early partnership with Dasi and the Piedmont Heart Institute, and hopefully you'll be able to capture also that you'll have for your own practice. So I think we're going to start off with Dr. Dasi himself for the opening lecture.
Thank you, Vinod. Good morning. All right, welcome everyone. So I'm going to basically open this session off just to give you a high-level overview of Dasi Simulations, what it is it that we do, and then hand it over to an excellent team of panel here to show you examples of how some of the products that we have developed could be utilized to benefit treatment planning. So the whole idea is about improved decision-making with computational predictive modeling. So here are my disclosures. So I'll start off with this slide. So how do you plan your trip to Orlando, Florida in the week of October 7th? And here's some expert consensus document that I found about best times to visit Orlando. And this is sort of how current planning happens. You have expert consensus, and if you look at the week of October 7th on this one, it shows that most weekdays in October is good. So you can actually go ahead and plan your trip to Orlando. But that's expert consensus, and computational predictive modeling shows this. For the precise week of October 7th, you have a disaster heading to Orlando, right? So that's the big difference between planning based on just consensus, which is sort of like almanac that has been derived out of many samples, versus what is going to happen for that one patient. So my job here is to just introduce to you the new paradigm for decision making, which I believe will be how structural heart will do all decisions in the future, and that's going to be dynamic predictive modeling. And most of you are familiar with devices that go in as an implant. So these are predictive models. They're software, but they're also a medical device as far as the FDA is concerned. So something to introduce to you is this concept of a software as a medical device that also has to go through regulatory clearance and then also is Medicare reimbursable. So this is something that is new and most physicians don't know about, but this is sort of the new paradigm that we are headed into for decision making. So at Dasi Simulations, here's basically what we have is we start off, if you think about TAVR, every TAVR patient gets a CT scan. So this software as a medical device that I talked about essentially takes the CT scan, develops a 3D model that you see the rotating image in the middle, and then you have this predictive model that I talked about that's shown on the right-hand side. So instead of just measurements that you use to plan, you actually now have a precise predictive model for that patient, and you can tell ahead of time how is that device going to basically interact with that patient's heart. And that's not where it stops. It goes into a whole generative platform. So here's where the product is actually already evolved now. So it's essentially an app that is a generative model, and it generates predictions as you, physician, are interacting with the app. So this is an example of a patient where you can actually drop in a Medtronic core valve. You can also take measurements between key anatomical landmarks and then see how those measurements sort of change with the deployment parameters or the device that you choose. And all of this is happening in real time as you interact with the app. So here's what generative lifetime planning could be done. So let's say you decided to go with a Medtronic valve as the first valve. You can then generate the scenarios for that second valve, and you can look at both the first valve and the second valve together and look at what the potential risks are for coronary obstruction, annular rupture. These color maps that are popping up show you the deformation of the aortic root that has been shown to correlate with injury. Not only there, you could also prepare for some procedural modifications like basilica or the shortcut device, where you might find that you could actually see, do you want to cut it right in the center, or do you want to put the cut a little adjacent? And that doesn't stop there. So you can think of this as many, many layers of prediction. You can predict PVL gaps and then correlate those gaps with what would happen potentially for that patient. So here's an image of one of the patients where the PVL gap could be visualized in 3D, and then you can also locate where the jet is going to happen. And this is sort of the data on which these models are trained. So there's a lot of echo data that has these real jets that can then be used to correlate. What about injury? So here's a 3D visualization. So no longer do you need to just depend on just the calcium score. You can actually look at what's going to happen to this root. So this is an actual root injury case. This is retrospectively done. And you can see these red hot spots where there's tremendous amount of deformation on the root that this valve has induced. So not only you can predict that, but you can go into optimization. So here's an example where you're optimizing, and as an implanter, you might think, hey, this definitely doesn't look good. Can I do a -2 cc or a -4 cc? How will that change things in terms of all of the other things that we talked about, like root injury, need for permanent pacemaker, or the PVL gaps? So that's basically where we're going with very precise predictive model. Here's an example of interactive vectors. These are contact forces between the device and the anatomy. So you can visualize what's the contact force within the membranous septum region, and what is that going to do with respect to the need for permanent pacemaker. And I could go on and on. We could predict gradients because you have essentially a large database where you know how the gradient is going to be. And this was just published earlier this year, where you could now predict post-procedural gradients from pre-procedural information. Even before you head into the OR, you have a rough idea what the gradient is going to be. And lastly, this was just presented yesterday at one of the sessions, is we can also predict thrombosis. So in summary, predictive modeling is where things are headed. It eliminates guesswork. And I'm really interested to show you the talks that are coming up from excellent panelists here. The overall goal is to democratize clinical intuition across centers. And we want to remove the variability. So I'll open it up for some discussion.
Yeah, that's great. Thanks, Prasad. I have to be honest with you, when you and I started talking in 2017, I didn't think that we'd be here in 2025, at a breakfast session at TCT talking about this. So this is really some remarkable work. And I think that especially as people go to a -2 or a +1, or the eccentricity that we see with self-expanding, we're seeing, continue to see halt. And I think that tying in with either eccentricity or the under or over expansion of valves is going to become important for longer term management of these patients. What do you guys think?
Yeah, absolutely. We've been an early adopter and totally bought in the concept. But Prasad, for our discussion here, maybe you can comment on the sensitivity and specificity of the two major feared complications of TAVR, coronary occlusion and rupture risk. I mean, those are the two biggest things that we don't want to have, none of us. So can you comment, like, if the ratio is less than 0.7, then are we pretty safe at that point?
Yes, so there's some publications that we have shown that the threshold that we have for coronary obstruction has a sensitivity and specificity in the upper 90%. For predicting root injury, the sensitivity and specificity is in the 85 to 90%. So as more and more data comes in, we can then revise and adjust these thresholds. But the real key here is to alert, because most of the times when these things happen, the physician has no clue, not even a hint that that's going to happen. Now that's not going to be the case. You will go in prepared, even if it's moderate or borderline case.
So, I mean, I think that makes a lot of sense. And I actually think the analogy, instead of Orlando, which I never really want to visit, is a road map that you open up. Remember, I'm old enough to know that I used to open up a map and then, kind of figure it out, to Waze, where on the fly it's telling you how to adjust your, I mean, that's a good comparison.
Right.
And so maybe we can hear from some of the other panelists or questions that you may have for Prasad.
Yeah, I think we were early adopters to it, at least within this past year, and have found incredible value in the more complex cases. We're making decisions about Basilica, or in the case I'll show Lampoon, and so it's allowed us to be a little bit more sophisticated in flagging us, as you mentioned, towards potential complications that are unique to each individual patient. And as volumes grow and complication rates inherently go down with new technology, I think this is the way that we're going to individualize treatments for people and still maintain those outcomes.
So if there are any questions from the, I know it's early and there's plenty of coffee in the back, but if there's any questions that you have, just pop to the microphone. It's a small enough room you can just raise your hands. Just feel free to do that. Any other questions for the panelists for Prasad?
I just have one comment. I love the fact that you can actually simulate the valve that is going to go in right now and whatever is going to happen 10 years from now when that valve fails, right? The simulation of the TAV in TAV, to me, is fascinating, the ability for us to understand whether we're going to have coronary access on those patients and simulate the depth of the implantation and the potential risks associated with that. More and more we treat low-risk in young patients, so I think I see a tremendous value of the software with that ability to do so.
Absolutely. Lifetime planning is so key.
Prasad, I wondered if you want to comment on the we have parameters to assess coronary obstruction risk that are well validated, but in some scenarios we have unexpected coronary obstruction, and your modeling predicts not only the movement of the frame but the leaflet movement as well. So can you comment on how you predict that?
Yes, I mean, traditionally most predictions have been based on things such as VTC. Here, because you're actually simulating the valve and the movement of not only the frame, but also where the native cusp and the leaflet on the cusp is everything's deforming, you're literally getting the precise view of what that flow gap is for blood flow and how much does it get constrained. So you're not really limited by anything else. You get everything you need to know to have a precise assessment for coronary obstruction.
Great. Before we get to the next talk, though, one last thing, and Prasad, I'm not sure you mentioned it. This is both FDA and CMS approved, and other technology. So it's, for all practical purposes, if you submit to CMS, you actually no cost to you and your hospital for the most part. And so that's something that's unique to this computer algorithms, which other computational modeling companies have tried to come to the U.S. and have not been able to have the data for the FDA approval. So, and Dasi has. So I think that's a great additional benefit.
Thank you.
So,
Yeah, excellent.
Great, thanks.
All right, let's move on to advanced planning for TAVR and bicuspid aortic stenosis by Hassan Jalavi from Cedars. Bicuspid, as we know, is still tricky. Prasad, we still remember your paper of all the calcified raphes in bicuspid, so
Thank you.
tell us more.
Yeah, it's a pleasure to present, and I'll show you some cases that just illustrate very well. So we're quite an experienced center, especially in bicuspid valve disease, TAVR. But even in our center, increasingly we've been asking for simulations, and in the very near future we'll have contract finalized for reimbursement. So in the past, we looked at this, and we still use this as a descriptive classification, but this is really pre-TAVR. It wasn't designed for procedural planning. So many years ago, we worked in various collaborations on identify what is a good TAVR case, a good bicuspid TAVR case. So we noted that some type 1 sievers would expand well, and others not so well. And we used this classification, but it was mainly descriptive, and it didn't quantify risk in any way. And then more recently, we had another multi-center series in low surgical risk patients, but this was able to classify high TAVR risk, intermediate TAVR risk, and low TAVR risk, but again, in a very qualitative way. So we found like around a quarter of patients were low TAVR risk, and a quarter were high TAVR risk, and around 50% were in the middle. So these are features, but as you notice here, these are qualitative features. So various low-risk features like a V-shaped orifice, Goldilocks calcium, not too little for device anchoring, not too much to impede expansion or result in injury, and sizing would be straightforward in these green light cases. In high-risk or challenging cases, we might see excessive calcification, asymmetry, LVOT calcium, low coronary, small sinuses, small STJ, or sizing would be challenging. So we did look at this, and we looked at various complications, and as you see here, there's a clear stratification, but if you bear in mind, more than 90% of these cases would have no immediate complications. So although we stratify this risk, if we send these patients that could have TAVR for surgery, maybe we would be under-treating. In some cases, potentially, we would do the cases, but expose the patient to disproportionate risk. So although these classifications have improved considerably, they are still qualitative rather than quantitative, and there's an element of subjectivity. So even in these high TAVR risk subsets, a lot of them still do well. They're designed not only to assess immediate procedural risk, but there's limited insight into long-term outcomes, which I'll allude to. So we want to avoid serious long-term complications, but immediate complications of concern, as Prasad mentioned, root injury, dissection, paravalvular leak, embolization, and coronary obstruction. So I'll show you some cases. So these are high TAVR risk cases that we actually ended up doing, and we do pretty much routinely, and often it goes well. So you'll see this case, 29 millimeter S3, quite severe raphe calcification, severe valve calcification. So we often underfill, and we do a double tap approach, and this is a modified approach to get a good immediate result. You did notice perhaps on the last slide there was a waste, and this slide as well, you'll see severely calcified case that went well with a good immediate outcome. You'll see again the ellipticity, which I'll bring into question at one point. So which one of these would you not treat? These are high surgical risk cases, all over the age of 80 or more, all with severe calcification. They all have severe LVOT calcium. The one on the top is 7% oversizing, this is 3%, and this is 10% oversizing. So it's difficult to say which of these had an issue, but one of them had a very serious issue. So here's the case that had an issue, and in fact, with severe valve calcification in type 1 bicuspid.
Pretty horizontal valve too, right?
Pardon?
Very horizontal valve
Yeah.
there.
Very
Yeah.
horizontal, and essentially had very severe acute complication, which was addressed rapidly, but obviously with enormous concern. So we looked retrospectively at this case, and if you watch the calcium, it actually becomes quite clear, the concern. If you look under the left main, you see this bulging, and in fact, in retrospect, we could even see this on the TE. So this biomarker with wall stress showed a 1.6 stretch, but it was actually 1.9. So 1.6 is the threshold for root injury, 1.5 to 1.6. And in fact, this case in retrospect was 1.9. So this is not a case that we would do. So I'm going to quickly allude to cases that go well, but we'll often see cases that go well, but end up with a waste. And what is the potential consequence of this? So we see it not infrequently. So recently we published on bicuspids and TAVR, and the incidence of a combination of under-expansion or eccentricity resulted in not only adverse immediate outcomes, but increased halt. But again, there was no precision medicine approach. So at the same time, we don't want to aggressively post-ill to optimize frame morphology. It's not always the right thing to do, because although we may increase the risk of adverse long-term outcomes in some but not all cases, aggressive post-dilatation can cause adverse immediate outcomes. So how can we guide decision-making in a more precise way? So Prasad alluded to this, and I won't get into it in very much detail. There's a very brilliant engineer, young engineer, Aniket, who's working on this currently within Dasi simulations. But essentially, you can predict leaflet thrombosis with a number of parameters. So in conclusion, bicuspid aortic valve anatomy is highly heterogeneous, which makes outcomes carry a degree of unpredictability. Although current classifications have improved, they remain largely qualitative, with limited ability to quantify risk in an individual patient. So simulation with Dasi offers the potential to address these issues with quantifiable biomarkers and offer advanced procedural planning. So this precision medicine digital twin approach, I believe, will very much be part of our routine practice moving forward.
Great, Hassan, that was great.
Thank you.
So, Pradeep and I would say that most of my surgical cases that I operate on now are AI or bicuspid AS. Mm-hmm. And the bicuspid AS patients that I operate on actually have been turned down by Dasi in having a stretch that's that high. So it's because we have a contract, we actually have integrated it within our valve team meeting that we do every Thursday, Friday. So it's interesting that my surgical patients are actually the ones that have been shown to have a TAVR complication.
So it's a very routine for us. All bicuspids will get this simulation, and it's oftentimes surprising that it's not the most calcified valve on 3 Mencio that has a high stress ratio.
Just like you showed us.
Sometimes, these spicules that you'll see, like last week we saw a retired orthopedic surgeon who doesn't look too bad on 3 Mencio, and we said, well, it's bicuspid, just send him for Dasi, and the rupture risk is 1.8. So he's not going to get a TAVR and likely going to go to surgery. One thing, we hear from our friends is, well, I've done enough bicuspids, I can do it. What commonly happens is what you showed, ellipticity. Like we're so nervous, we don't fully expand the valve. Yes, but that's not the right thing to do. I think sometimes having your simulation report that, yes, you can go. You have enough room. You can go to full expansion here. Will give you a better hemodynamic result, better valve performance.
And it gives you the ability of understanding how far you can go. Because when we see that ellipticity, we tend to, let's dilate with a little bit more volume to make it more rounded, right? And this is, we know, I think that having that information increases your confidence and how far you can go in that specific case.
And sometimes, you may not want to go. Like a 90-year-old, not a surgical candidate, high rupture risk. Yes, you're going to accept a borderline result, but a lot of these bicuspids are younger patients, and we know again and again we cannot have underexpanded valves with waste.
And I think that also what'll become important for a self-expanding prosthesis is, this is the patient, I'm going to deploy it for whatever reason, that's your valve of choice, you're going to use that, but we're going to probably do a second post-dill of this, just to make sure that we're getting a little bit less eccentricity for this.
It's also the positioning has been very interesting, simulating various positions of the valve and kind of quantifying the risk. You know, as you said, Vinod, often very experienced. So even our group is very experienced with Raj Makar. To be honest, sometimes we look at cases and we see a case that goes very well, as you've seen, and then there's really nothing discriminating looking at the case. Why? And sometimes it's the orientation of the calcium. It's not just there's the calcium quantifiable, but it's the orientation and the potential risk. It's not always on the side of the calcium. Sometimes it's the other side, and incomplete expansion on one side results in bias of the frame, and it's actually the frame that causes the injury rather than the calcium itself.
And there is no way of predicting that based on static 3-Mensio imaging, right? The raphe is not going to split. The whole valve moves to the opposite side, and we kind of guess it, but there is no way to measure it.
Yeah.
Absolutely. Well, let's go. Do you have a comment? Or
Yeah, I was
should we
going to
go?
say, these are the cases that occupy the most time in our valve conference, the 65 or younger patients with variable anatomy and bicuspid valves, and we're just with Gestalt trying to determine their PVL risk and their annular rupture risk. And so having lifetime management hemodynamics and being able to pick which valve first, plan for the second valve in these younger patients, and avoid complications with the first procedures can be incredibly useful as we go forward, more of these borderline cases develop.
Well, it becomes actually a discussion point for our patients, so that, you know, everybody wants a TAVR. Nobody wants their chest open. And so when we come back and say to a 65-year-old, hey, listen, we did your simulation. We could do this, but we have a very high likelihood of complication. Nobody's come back to us and says, the hell with the computer. Just do it anyway. Let's just see what happens with this complication. Nobody says that, and it gives us a little bit more reliability in our conversations, and they usually don't argue with us at that point.
Yeah, we pull it up in clinic because sometimes, you know, patients demand TAVR, and, you know, they're in that range, 65, 70. You look at the calcium burden high, but, you know, patient really wants it. So it's easy to get sucked in and just go for the procedure. But this gives you a little more confidence, and you show them that this is a complication risk when we're not going to do it.
Yep.
And they see it, and it's like, okay, this makes sense.
And it's within Epic for us. So within Epic, we can sit there in our room and double-click on media, double-click on the PowerPoint presentation. So we actually are showing it to our patient, the algorithms, or the PowerPoint slide set. So Guillermo, let's go ahead. Guilherme Atizani is going to talk a little bit about using this technology as self-expanding valves.
Thank you, Vinod. So we're going to talk today a little bit about the advanced planning for lifetime management and self-expandable TAVR. These are my disclosures. I'm going to start with right out of the bat with the presentation of our patient. So 64-year-old, actually this conversation we had before was a good introduction for my case. Severe aortic stenosis, symptomatic, obviously low surgical risk, right? A normal sinus rhythm in the EKG and a BSA of 2.1. This is the echo of the patient, obviously severe aortic stenosis. Coronary angio, nothing really remarkable. And these are, I want you to pay attention to the anatomy of this patient. These are the measurements. You can see an area of 3.8 with a perimeter of 72.9. Sinuses are wide, as well as the STJ. And the question is, which valve I'm going to choose to this young patient? Obviously, surgery was discussed with this patient, and as our panelists pointed out, some patients, they do come to us, they do not want to undergo surgery. And I have to provide this patient with a good planning of a long-term lifetime management for this patient. So if I put on this patient as S3, 23 millimeters, you can see here that this patient would end up having severe patient-prosthesis mismatch. Whereas if I choose to put an Evolut 29, the patient would not have patient-prosthesis mismatch. In addition, obviously, considering that this patient would have been a SMART trial patient and the performance of the valve has been shown to be better, I think I would rather choose a 29 Evolut in this guy, even because I do not want him to have a patient-prosthesis mismatch, as I mentioned. So this is the simulation of the expansion of the 29 millimeter FX Plus valve. In this patient, you can see that the valve expands very well, and the valve is very distant from the coronaries as well as the leaflets you can see there. And as what was mentioned before, right, the risk for coronary occlusion in this patient would be extremely low for both coronaries. And this is also a very interesting case because it is right in the borderline between a 26 and a 29 evolute valve. And you can see that with the Dasi simulation, we can actually predict the risk of paravalvular leak. You can see with the 26 valve, the risk would be higher than the 29 valve. Although there are no clear thresholds for this measurement, it's intuitive to see that the 29 valve would have there a less or lower risk for paravalvular leak. Of course, measuring the membranous septum in patients that young is extremely important for us as well, because you need to understand the higher you implant these valves, the more difficult it's going to be to have coronary access in the future. Therefore, we feel that that's very important to measure the membranous septum, even consider even implanting the valve a little lower as long as the membranous septum looks good. We have shown before that coronary access after evolute FX implantation is doable as long as you have commissural alignment. So we were able to cannulate 100% of these coronaries in the series that we published on JACC intervention. And because of that, we also looked at the angles of the coronary, so the distance between the right and the left coronary here, to understand what is going to be the chance that we're going to have the larger windows of the FX plus in front of the coronary ostia of this patient. As you know, these windows are located 120 degrees apart from each other. And it is important, and this we were able to, Dr. Dasi provided this information to us, that because the windows are very large, obviously the coronaries are not always 120 degrees apart. Therefore, we need to understand what is the minimum range and the maximum range of the distance of the coronaries that we can actually have the windows in front of the coronary ostia, and these are the values that you see on the right-hand side of the table. And with Evolute FX Plus, the ability of cannulating these coronaries is we can cannulate them quicker. This is data that we have just submitted, but it's easier to cannulate. But we need to understand now, can we go through the coronaries after the procedure? And can we go after the procedure 10 years from now that we're going to do a TAV in TAV on this patient? So you can see here, this is a beautiful simulation that you can see the larger windows of the FX Plus right in front of the coronary ostia of that patient. This valve was simulated at 4 millimeters depth, the implantation. But we also need to understand what's going to happen down the road. After this valve fails 10 years from now, what's going to happen if I put a sapien valve inside that evolute? Is this patient going to have ability, where we're going to have the ability to cannulate his coronaries? And here you can see where we can simulate the beauty of the technology is that we can actually simulate the position of the sapien valve down the road in different nodes of the evolute valve and understand whether or not we would be able to cannulate those coronaries. So node 4, node 5, and I'm going to show a very interesting image here. So those thresholds that we mentioned before, so with node 5, you can see here that the risk for potential coronary compromise would be higher if we implant that valve on node 5 down the road. However, if we implant that valve at node 4 down the road, then there's the risk for coronary compromise, flow of coronary is going to be very, very low. And not only that, I want to see also the ability of having coronary access, because we're talking about two different things here. One of them is an acute compromise of coronary flow, and the other one is, can we actually cannulate those coronaries? And you can see here, when we implant the valve in node 4, while there is a possibility for us to cannulate those coronaries, I want you to pay attention to the difference between node 4 and node 5. As you can see with node 4, we have a much larger space to cannulate those coronaries, right? So what I'm doing here basically is providing to this patient the whole plan, not only after I'm going to put the first valve, which I want to put a valve that delivers a better hemodynamic to this patient, but also when that valve fails down the road, what am I going to be able to do and what's going to be the results that we're going to have in the end. So just to finish here, and I would like to open for the discussion with the panel, is that the Dasi software allows for a comprehensive procedural planning and lifetime management considerations, that this is progressively more important as we treat these younger and lower risk patients.
So the customized TAVR is crucial for these young patients, and not only impact the procedural results, the acute results, but also helps us understand what's going to be the result down the road when this patient requires a TAV in TAV. Thank you very much.
That was fantastic. You're obviously such a high volume operator. So walk us through a little bit of what your practice is. Are you doing simulation on all your younger patients, and are you modifying the technique of your initial implant also based on their second, like, sometimes you may have to deploy a little bit deeper to open the door for further?
Yeah, Pradeep, that's very, very important, right? As you know, right, we, with all the story of pacemaker rates, for example, for Evolut, right, so we started implanting these valves higher, but we're going to pay a price down the road because the coronary access is going to be higher, the ability to do TAV in TAV, of course, right? So yes, so we have been customizing our approach for our younger patients. That it's crucial to understand, right? Exactly as you said, if I implant my valve a little bit deeper, I'm going to open room down the road for a TAV in TAV. And so yes, we have been doing that consistently. And then incorporating this to your workflow is very, very easy. And I think Vinod made a very important comment, which is you can actually show to the patient, right, what's going to happen now and what's going to happen down the road. The information, the visual assessment also for the patient is very reassuring, right? So yes, I think it's crucial to do. And as you pointed out before also, sometimes we can plan that in our mind, but when you see like a regular software, but when you actually see that in action, right, it's different. It provides me more confidence and to provide a good result for this patient.
So, all of our TAV and TAV and all of our TAV and SAV, we run through the program because it allows us, especially for Basilica, we do a lot of Basilica. We actually do a lot of Lampoon. And for us, it gives us that confidence that what we're going into is going to give us relatively, assurance of a less than a 1% morbidity and mortality. So, go ahead.
That's incredibly useful, and what we see the value of exactly what you showed in that case. I tell patients that we don't have a crystal ball, we can't predict the future, but this is the closest thing that we have right now is computational modeling to try to predict the future. And the way that you incorporate that in your planning, knowing the membranous septum is 6, knowing that you usually implant high, but knowing that you want a node 4 implant in 10 to 15 years, incorporate hemodynamics into that and PVL risk on top of that, we'll soon be able to make valve selection decisions based on individual patient characteristics. And the patients that are asking, am I going to get through this procedure or not, now asking how long is this going to last and what are we going to do afterwards, we can provide them some level of prediction of the future. And more importantly, when you go into that procedure, now you can plan more sophisticated exactly where you're going to implant and where you're going to implant next. So it's incredibly powerful. That was a really awesome representation.
One of the counter arguments you hear is, well, the pacemaker in a younger patient's not good, and every millimeter ventricular position is going to have a pacemaker risk. But it turns out that the simulation will actually give you a pacemaker risk at what depth, right? So in some patients, you can afford to deploy it just a millimeter or two lower.
Yeah, in fact, we have been consistently doing that in patients who are younger, right? We don't try to aim at like a 1 millimeter or 0 implant, rather the opposite, as you said, right? Because having that confidence, knowing where the membranous septum length is, right? Then having the confidence to implant a little deeper, to then enable in the future, in this specific patient, even more so, because we're doing a lot of oversizing with a 29 valve. So I have the confidence to implant deeper, knowing that I'm going to have no PVL, despite that I'm a little deeper, and still no conduction disturbance, and then the ability to do TAV in TAV in the future. That's very reassuring.
It also dispels a lot of the coronary reaccess issues as well. So if your colleagues are cathing that patient in the future, and if you have it in EPIC, you can pull up that simulation to show them exactly which cell to go through. So
Hassan, did you have a comment?
Yeah, just with regard to pacemaker, Guy, as you alluded, so there was a phase where we were implanting very high or implanting high in relation to membranous septum, but we also know there are many factors involved in pace, many anatomical factors. So it's not only the membranous septum, but it's the degree of stretch in the LVOT, and also the device landing zone calcification. So those things in themselves, we know them to be risk factors and also synergistic to risk for pacemaker, but summating that is very difficult. So what this does is it summates it to provide a biomarker that summarizes in a way that we can't fully understand in an individual patient otherwise.
Well, that's fantastic. In the interest of time, we'll keep moving to next talk, Real-World Complex Decision-Making with Dasi Simulations by Dr. Matt Summers.
All right, thank you. I'm going to show a valve and Mac TMBR case that we recently did, and it highlights a lot of the sophistication that these simulations provide when these borderline measures that we've been using historically sort of fall on either side, and we have a lot of adjunct procedures that we can perform, like lampoon and septal modification, to help mitigate some of the risks that are inherent with valve and Mac TMBR. I have no relevant disclosures, but this is an 81-year-old female, pretty typical case that we're seeing at increasing frequency. Multiple heart failure admissions came to us after her third admission with decompensated heart failure. You can see pretty typical circumferential calcific mitral stenosis, MAC, high transmitral valvular gradients, a mean of 18, relatively small ventricle for her body size. She was a little bit larger of a lady, but hyperdynamic with an EF that's over 65%. No significant MR, 2+ moderate. This is her TEE. You can see with 3D MPR, the circumferential nature of the MAC, the 2+ MR, the inflow acceleration, and the small LV cavity with pretty large left atrial dilation. Coronary angiogram didn't show any obstructive coronary disease. You'll notice on the left there's long left main, and particular note of the septal anatomy there, which I'll show in a minute. We had some elevation and right-sided filling pressures, pretty typical hemodynamics, right heart cath for mitral stenosis with borderline indices. So this patient came in, like all of these do, needing IV diuresis and cautious diuresis at 81 with some borderline renal dysfunction and AFib, but mostly her age and body mass index. Her STS was 14%, so she's prohibitive surgical risk. We have access to 2 TMVR trials. We screened for both of those. It wasn't just the quantification of the MR, it was mostly screen fails, which is a common problem, as you all know, for risk of neo-LV outflow tract obstruction. So this is how I do processing. We end up doing quite a few mitral processing, CT reconstruction ourselves. And this is the classic way that we've done it for several years that we're all familiar with. When I did that with a 90-10 implant at 30% RR, so really a mid to late systolic phase, we were getting neo-LVOT measures around 100 millimeters squared. We had anatomy with a MAC score of 8. We had anatomy that, depending on how you slice it through, the calcium was between 580 and 720 for CSA. SL and AP dimensions looked okay. But because of that, we knew we had to have valve and MAC TMBR, and we thought we were going to end up needing to do septal reduction and leaflet modification. The left heart cath, you see long left main, and really that first septal arcade is pretty distal. And given her myocardium and sort of the nature of where that septal was in relation to how distal the LAD septals were, we felt that it was just poor septal targets. This is a procedure that's been described previously by the folks at Emory. And Scorpion, we have a couple patients that we had sent for this historically. A new electrophysiologist, one of our partners, performed this Scorpion for us, given the poor septal anatomy. You can see on ICE imaging there, you see septal edema. There's this retro aortic ablation catheter, RV ablation catheter, and his voltage map, which shows in red the ablation points. And so he performed that Scorpion based on our initial pre-procedural planning. This is before we had done mitral planning with Dasi. And she was doing well at 6-week follow-up, but still had ongoing class 3 symptoms. And we repeated our CTA to look at the neo-LVOT again. Given the ongoing success that we had, similar to the other panelists, with complex TAVR planning and a lot of similar cases where we found incredible value, we submitted this to Dasi. Their mitral planning is not quite as developed, from my understanding, as the TAVR planning that we've seen, but there is some really sophisticated measures that allow us to reassess this in a more sophisticated way. So this is my reconstruction after the 6-week Scorpion, post-Scorpion. And I thought that I'd still need Lampoon. We're at 240, so it did go up. But she, if you index that to her body size, it's still a little bit concerning. We were obviously above the 1.7 to 1.9 and 2 measures that some people use, but 240 with a lady that was a little bit larger, we thought was still concerning enough to consider leaflet modification. But then we submitted this to Dasi. You can see on the right there, the atrial and ventricular views, how the leaflet is restricted and where the calcium pattern is. We simulated a valve and MAC TMVR with 3 cc fills, 3 cc fill volume at 90-10 deployment. And it was actually much more capacious in the LV outflow tract than what we had predicted by our historic planning process and reconstruction process. So diastolic and systolic LV dynamic, you can see through all phases, which is one of the very difficult parts of valve and MAC TMVR planning, is that you have to do that processing at several different phases and at several different levels. So this provides a three-dimensional representation, a dynamic representation of what happens when you implant that valve with the leaflets. It takes into account its leaflet length, and that measurement of neo-LV outflow tract is much more sophisticated. And so they were getting a neo-LVOT measurement much higher, 322, at a more late systolic phase. More importantly, I think, is this PVL prediction risk. This is a very common problem, as a lot of people know, with valve and MACs in particular. We're looking for gaps between the frame and the MAC, and there really wasn't any PVL gaps identified, and so no PVL predicted. So we proceeded with valve and MAC after this, septostomy with a 14 tie shack. Was crossing the valve with a pig, all done on 3D MPR. And you can see this is a little bit of a slower deployment, but we ended up with a 90-10 deployment. Playing quite a bit slower.
Will be interesting to see PVL, these valve and MAC, as you said, PVL is a problem.
Yeah, and I think that was the more impressive measure here is it really flagged us to where PVL could occur in prior cases, and in this, we didn't really have a location for it to occur.
Yeah, and plus you're not worried about root rupture, you're worried about PVL. Very different, or coronary obstruction, right? You're worried about other things.
I think LVOT we kind of measure reasonably confidently, but the PVL and the valve stability, is it going to migrate? Is it going to stay to still issues?
Yeah, that's great.
So this is the final. Here we had 0 PVL. We had a peak to peak LVF flow tract gradient of 4 and a mean transmitral gradient of 3. We ended up closing the ASD, some right-sided dysfunction as well. She was discharged on post-op day 2, and at 2 months follow-up, which I saw her 2 weeks ago, she's doing incredibly well. So I submitted this. This is just very briefly advancing through. I apologize. So we went back and looked at the CT from the initial, the index one. We had them retrospectively look at that to determine whether we needed to do the scorpion in the first place. So they had a more sophisticated modeling process to really plan for septal reduction and leaflet modification. So when they did that, the numbers actually on that index CT were more impressive as far as the size of the predicted LV outflow tract. So we compared the simulated stent from the initial pre-scorpion and the post. We got a CT scan at 8 weeks in follow-up. And you can see the alignment there is very, very close. So the predictability of it was very close. They're starting to do these LV remodeling and morphology measures, which is pretty interesting. It's hard to compare with the different phases, but there was some change in LV morphology at 8 weeks. And then how accurate were these simulations? This is the post-scorpion one initially, the 322. We ended up a little bit lower. This has been described as before, that your completion LV outflow tracts are usually a little bit lower than what your predicted are. And then simulated PVL risk versus post-valve and MAC PVL risk were all in line with what we saw. But was the septal modification necessary, which is the important part? We ended up doing this, and it was, it was safe. The patient got through it, but did it work, and was it successful, or was it necessary? And back on their original reconstruction of the first index CT, it looks like we probably wouldn't have needed to do septal modification.
Would not have needed it.
Say what?
Would not have needed it.
No. And so that's what we found incredible value. And just to summarize is,
that's cool.
It's cut our basilica rates. We do a lot of basilicas and leaflet modifications. Cut our basilica rates almost in half. We have had no increase in coronary occlusion risk, just with more sophisticated measures, now validated measures of coronary occlusion. As we build into this much more with cases like this that are complex, and we have several of these measures that are prone to measurement errors, I think this is going to be incredibly useful.
Yeah, that's super. Great job.
Totally echo your basilica rates. Like, if nothing else, rather than bilateral basilica, it goes to unilateral. Oftentimes it turns out that the right's going to be okay. You just need to do the left, or vice versa.
So I think that's a great example. And maybe, Prasad, you can kind of comment a little bit on where is the future going? I mean, this is, you have valve and MAC. I mean, we have, valve and ring. We're doing a lot more transcatheter work on everything, either de novo or after a surgical intervention. What's the limit here?
Yes, I mean, although like there's so many new areas like Evoke, like tricuspid replacement, edge-to-edge repair, and it goes beyond just structural heart, maybe potentially into the coronary, even endovascular, neurovascular areas. So I would say there is no limit in terms of the technical as well as the clinical. The other thing that's going to happen, I was going to comment when Gui presented his excellent talk, is that this sort of technology will also innovate new techniques in the cath lab, potentially, because now you're able to see things in 3D. You could actually modify your deployment parameters, let's say for coronary alignment, things, or like, inflation volumes for the SAPIEN.
So I tell you, I know there's at least one surgeon in the room, Kim Holtz back there, but what we've been discussing in just recently in mitral valve forum for surgical repair of mitral valves, which still has a 20-30% failure rate at 1 to 2 years. It'd be nice to know, should we do a P2 resection or should we do P2 cords? Can we predict SAM better than we are now? So I see the sky's the limit, not on catheter, but just the word valve kind of becomes synonymous with kind of having better computational modeling. We got to get out of this MapQuest type of thing where you printed out your directions and then you crock your miles and say, okay, 0.1 miles, I got to turn right here. You got to be able to have it automated for you, I think.
Yeah, need for root enlargement, yes, there's root replacement, a bicuspid repair. Yes, truly there's no limit for.
So I've got to run. I've got to give a talk actually at 7:30. So Predictive is going to take over, and you guys continue to have fun. And if anybody in the audience has any questions, obviously the team's around, and call me either.
Yeah, go ahead, Pete.
Just one comment that what we're working now for in terms of coronary access is that we're trying to understand now whether we can use the prediction models to actually customize the rotation of our catheter to optimize the position of the bigger windows in front of the coronary ostia. So now we're trying to understand, first of all, if we just put in the flush port at 3 o'clock, whether or not we're going to have those windows in front of the coronary ostia, and not all the time that's going to happen. But the next step is how we can customize and use the information of the pre-CT to then react in the cath lab and then modify that position of the flush port to then prioritize, for example, a patient that has a Lima to LAD want to prioritize those windows in front of the RCA if they are too far apart, the coronaries. So we're working on that now. That's our next step in terms of the prediction models and how we can have easier access to the coronaries.
Well, that's outstanding. To stay on time, let's go from highly technical last 50 minutes to highly non-technical stuff. But that's actually what's going to pay for your simulation. So I'm on the advisory board for Dasi Simulations, but let's talk a little bit about how to incorporate this report in your workflow, right? I mean, if your administrator is not willing to support it, your hospital's not going to let you do this. The first point is that it is FDA approved and CMS reimbursed, right? So you're not paying a penalty for this. You're not paying out of the pocket. Your hospital needs to understand this. So regular TAVR flow is patient gets a CT, is measured by either a radiologist or a cardiologist or the industry rep, and most hospitals are having a heart team meeting. You discuss that report in a heart team meeting. You pick up whatever valve size access therapy you're going to do. And sometimes there are questions that come up. Well, that coronary looks low. We need to remeasure it. And oftentimes, either the imager or the proceduralist, surgeon, interventionalist will go back to the Tremensia, open it up, remeasure it, and let's rediscuss those challenging cases. That's the usual workflow. So the question is, how do you incorporate simulations so that it actually runs in parallel and really eliminates any delay in your care. And I'll try to share what we do, at least at our centers. The first question is, which patients do you get simulations? General high-risk anatomies are you're worried about coronary occlusion, you're worried about annulus injury, sinus injury, and as we looked, lifetime management. So you can have a team consensus, what are the cases that you are worried about, and then form what points you're going to look into. This is what our team over the last 4 to 5 years have evolved into, and this is our pretty standard of care. All valve-in-valves, regardless what their STJ, coronaries looks like, everybody is going to get a simulation. All bicuspids are going to get simulations. High calcium scores, very calcified valves, you want to see how well the valve is going to expand. Those patients, any red flags that are coming on the internal measurements, sometimes our cardiologist will read and say sinuses are really effaced, or any red flags for coronary occlusion, we'll send it for simulation. And then finally, lifetime management is actually starting to pick up, and patients are asking us, now they're starting to hear this, like, hey, these are going to last 10 years, what's going to happen in 10 years? So at least that's our consensus, and at least in our program, it turns out it's about a third of our volume. So a third of all the TAVRs, they end up getting simulations. The goal is eventually, right now it's a bandwidth issue, but once we have all the bandwidth on Dasi side and our side, every patient should get it. There is no reason to do a TAVR without proper planning. If your family member is getting a TAVR, you do want simulation and to have that degree of confidence. So as soon as the CT is done, the coordinator has these parameters, and for those patients automatically sends the report to Dasi. So when we do our valve meeting on Thursday mornings, we do have both Tremencio and the simulation report to then make a decision right off the bat. And we can decide basilica or whatnot. So this is a little complicated, but this is where what happens in the backflow. Once the coordinator, and you may want to take a picture of the slide, what happens when a coordinator identifies a patient? How does that go? The first step is coordinator will place an order in Epic. This is the EMR that we use, that notifies our CT department that, okay, this patient needs a simulation. CT department then creates an appointment and requests for pre-authorization, since it's a CMS-approved test. Once that appointment is created, our PCC department will work on the authorizations. Once we have reimbursement authorization, the CT department is notified again that, okay, now you can have the go-ahead and do the exam. And all they do is they open an encounter, a new encounter, separate from the initial TAVR CT scan. Open an encounter and close it. And that is enough, and that notifies the valve coordinators that your encounter for 3D simulation has been completed. And that, after that step, the coordinators are allowed to forward the CT and upload that CT to Dasi Sim Lab. And it takes 24, 48 hours, 72 hours to get the PowerPoint, all the images that you saw, and then we discuss that in the meeting. We do have some help from the company on this. If the biggest roadblock, honestly, in expanding this software to multiple hospitals is getting into your system by the legal language, by the reimbursement people. Even though we've been working with them for 4 or 5 years, it took over a year to get this process sorted. Kyle Fortman is our director of Valve Center. He's here in the audience. He helped design all this, and maybe we can share his contact at the end. If you have any questions, please feel free to connect us, and we'll be happy to work with your team. The other point is that CMS reimburses for each simulated valve. For example, if you have Evolut and Sapien, you will get reimbursed for both of those valves. That is in the CMS guideline. And sometimes, you don't need 2 valve simulations, but sometimes you do. If it's an annular rupture, you do want to see what is the self-expanding risk. And if you're planning lifetime management, you do need multiple simulations. So that's the message, that you can get reimbursed for individual valves rather than just one for the report. Also, the last point we emphasized earlier, due to the nature of the billing code, the appointment has to be separate then the initial TAVR CT scan, and ideally at the same location where the CT was performed. So I think those are the things that I have on that, but the mic is open. Please come up and ask any questions if you have, and Prasad and Guy.
Pradeep, I love that you showed the workflow in your institution, because this is something that I'm sure a lot of people in the audience may be asking themselves. Just a quick question for you. In terms of denials, when you submit, how often do you get denials? How do you handle that?
So we're starting to see it, and Kyle, maybe you want to get up to the microphone since you're dealing with this.
We've been doing this since about May, June, and honestly, we've probably only had one denial so far. And this came recently in the last couple of weeks to a month. Otherwise, we've sent quite a few
But it is like anything, you know, we still get denials for TAVRs, right? Blue Cross Blue Shield less than 65, impossible to get TAVR in Georgia.
And you've tested reimbursement on 2 simulations, like if we're choosing between 2 different valve platforms, have you had a similar patient with both simulations?
Correct. So we're approaching that topic right now. RevCycle has denied that to us right now. I'm going to make the clinical push to explain to them why it really is 2 different simulations and why we need to get reimbursed for 2 different. There is a CMS ability to get reimbursed for both of those. We don't know in the end, we may have to pull out both simulations and then put them in Epic separately and say, look, we're going to do this one and we're going to do this one. That initially we weren't putting them in Epic, but as we went through RevCycle to show that it is in Epic, we do now upload it into Epic, so it's searchable and queryable for CMS.
Yeah, so when we started in June, July, for looking at this reimbursement, we said, let's do our next quarter, and then at the end of the quarter, we're gonna come back and see how many cases actually got paid and what was the payment and did hospital lose money. That was the deal with our administrators, and Kyle, you looked at the data recently. What did it show?
I can't give you hard numbers right now, but it's pretty favorable reimbursement. It's not, we were hoping to break even on it, and we are definitely not breaking even on it.
Yeah.
We're doing pretty good.
Okay. Prasad, your final comments?
Yes, thank you for all that great discussion. One of the final things, in terms of workflow, we are evolving, and pretty soon this would be integrated into the PACS. So pushing the CTs would be pretty seamless. And then in my talk, I presented the app, which is the other piece, is PowerPoint presentations versus becoming very interactive with real-time generative modeling is where this is going. So the nature of the report will also change over time. So there's a lot of changes coming very quickly.
Well, that's fantastic. It was a great session. Thank you for your attendance, and we'll close the session here. Thank you.
Thank you.